This is the LSU. It's the suction unit that we use to remove fluid that's obstructing a patient's airway. So you want to ensure that the suction unit is fully functionable. So you want to check all the pipes and the tubing, the seals, check everything's in the right place and it's put together correctly. You want to dismount it from the wall to perform the suction test to check that the battery's also working. So you're going to hold down test, you're going to turn it up to full, and you're going to occlude the tube. It should rise to 500 millimeters of mercury plus, and then turn itself off once it's passed. So it's passed its test. It's telling us that the battery's full. If the battery wasn't full, you would replace it with a new one. For suctioning a patient, you want them in the lateral position to help the fluid sort of move naturally out of the mouth, turning their head laterally. There we go. There are two types of catheters. There's a rigid catheter and a soft catheter. I'm going to go ahead and turn on my suction unit. There we go, it's on. I'm not going to suction on the way in, I'm only going to suction on the way out. And I'm only going to suction as far as I can see. Okay, there we go. So I'm occluding the hole on the top of the rigid catheter, suctioning in a circular motion and on the way out of the mouth for no longer than 10 seconds. There are some complications with suctioning patients, such as stimulating the vagus nerve at the back of the throat. This can cause bradycardia, so slowing the heart down. If you suction for more than 10 seconds, it can cause hypoxia. Along with using a rigid catheter, you can cause some soft tissue damage to the oropharynx and the tissue around the mouth. For this reason, you will not use a rigid catheter in a moving vehicle. So an OPA or an MPA can be used when a patient's airway needs to be maintained. Generally, the patient will have a GCS of 8 or lower with a motor score 5 or less. So before inserting an OPA or an MPA, insert a towel just underneath their neck to help achieve a head tilt, chin lift position, opening up their airway. So this is an OPA. You want to measure it from the corner of the lips to the end of their mandible. You can see here that this is the correct size for this patient. You're going to insert it upside down, so with the point curving towards you. You're going to insert it, you're going to scoop it around the patient's tongue 180 degrees, and it should fall nicely into place, resting against the patient's lips and teeth. It can act as a bite block, and complications of using an OPA is that it can stimulate the gagging reflex and causing the patient to vomit. It can also cause soft tissue damage to the roof of the mouth and the oropharynx. Some patients can't tolerate an OPA, so that's when you'd use an NPA. These get inserted into the nasal cavity. So with an NPA, they can be tolerated by semi-conscious patients. So you're going to measure it from the end of the nostril to the end of their mandible. You can see here that this is the correct size for the patient. As it is going into the nasal cavity, you want to use lubrication to help it slide easier into place. So you want to use a decent amount of lubrication, as it can cause some complications in the nasal passage, such as bleeding and polyps. You'll then choose the larger of the two nostrils, so that's this one here, and you're going to insert the NPA perpendicular to the patient's head, so not upwards. Okay, if you encounter any resistance, you can twist it 180 degrees. Contraindications of using a NPA is that if patients have a TBI, so a traumatic brain injury, or a base of skull fracture, you wouldn't use it. It can, just like the OPA, it can still stimulate the gagging reflex and cause vomiting, but it is generally more tolerated by patients that are semi-conscious. An NPA can also be used in patients with trismus. So this is an oxygen bottle. You can tell it's an oxygen bottle by its white in colour. Usually they'll have a oxygen label slapped on it and some other tags on it. You can also tell it's an oxygen bottle as it's got two holes here on the pillar that line up with the two prongs on the oxygen regulator. Before attaching a regulator to an oxygen bottle, you want to ensure that the Botox seal is intact and there is no wear or tear around it. This Botox seal is looking pretty good, so I'm going to go ahead and attach the oxygen regulator to the bottle. So over the pillar, line up the two prongs with the holes, and then tighten the screw at the back, giving it a quarter turn to fasten it. Open the pillar valve. There we go. So it's showing me that this bottle is about half half full. Patients that you would use oxygen on are patients with a low SpO2, so anything below 94%. Quite a wide range of patients you would use oxygen on, so just keep that in mind. You also want to check that the flow rate's working, so everything's working there. Mantle it. So I'm going to turn off the pillar valve. I'm going to bleed the regulator. To dismantle, I'm going to unscrew the screw at the back. So this is your bag valve mask. It's used to ventilate patients. So make sure that there are no leaks within the bag or the oxygen reservoir. Bag valve masks deliver a high flow rate of oxygen, about 75 to 100% per minute. You want to attach a filter to the end here. This will just ensure that if the patient does happen to vomit, that it won't enter back into the bag or the oxygen reservoir. You then want to attach some tubing to the bottom here next to the oxygen reservoir. Make sure it's on nice and tight, and then you want to attach it to the nozzle on the oxygen regulator. I'm going to turn my pillar valve on. I'm going to set the flow rate of no lower than 15 litres per minute. There we go. We can hear the oxygen's now running, and the bag, the oxygen reservoir is filling up with some oxygen. So I have an OPA and an NPA already inserted in my patient. I want to make sure that the mask is the right size, which it is. I'm using a CE grip along with a towel underneath the neck to perform a head tilt chin lift maneuver. This will help open up the patient's airway. So you want to ventilate a patient once every 5 to 8 seconds and assess chest rise. So I got good chest rise on that time. If you're not getting chest rise, you might need to consider if you're inflating the patient's gastric tract or using the acronym MOANS. So the point of hemorrhage control is to stop the bleeding as quickly and efficiently as possible. With a hemorrhage that is not catastrophic or life-threatening, it's always a good idea to ask your patient's consent just so they're aware of what's going on. You want to expose the wound. If you find the wound is deep and or dirty, irrigate it with saline and then consider packing it with gauze that you've soaked in saline. Once you've exposed the wound, you then want to get a sterile bandage that is the appropriate size for the wound. So it needs to be the smallest size possible to adequately cover the wound. You want to get some saline and you want to moisten the dressing. This will help keep everything nice and clean and prevent the combine dressing sticking to the wound. If your patient is conscious, you can get them to apply pressure to this combine dressing, and then you'll get your bandage out. You want to applying direct pressure to the wound in hopes to stop the hemorrhage. So you want to pull it tight. To achieve more pressure, you can twist the bandage twice and then pull down over the side. Once you've dressed it, you want to check the peripheral pulse on both arms. You want to check the cap refill, check the colour of the skin's the same, and just make sure that the patient hasn't got any altered sensations, as you may have done the bandage too tight. If the patient continues to bleed through this combine dressing and bandage, you can apply another one on top to try and achieve more pressure to the site. Alternatively, you can use indirect pressure, such as a bandage underneath their armpit. Catastrophic hemorrhages, such as severing an artery or amputation of a limb, you would apply a combat tourniquet. So these need to be applied to single-limbed bones, such as the humerus or the femur. Upon applying a tourniquet, you want to make sure that the patient has received an adequate amount of pain relief, as tourniquets are extremely painful, and want to secure the tourniquet 10 centimeters proximal to the wound site. Arteries are elastic, so it needs to be at least 10 centimeters because they can retract back up into the arms or back up into the legs. So for this, I'm going to say it is a laceration just below the elbow joint here. So I'm going to go and tighten the windlass until the bleeding has arrested, or the distal pulse has disappeared. Okay, I'm going to say that the bleeding's arrested. I'm going to secure the windlass and document the time that the tourniquet was applied. You want to keep the wound exposed, and if you notice that bleeding has started again, you can apply a second tourniquet proximal to the original one. A cervical collar or a C collar can be used when a patient has a suspected or confirmed C-spine fracture. So there is a few criteria that you want to make sure your patient meets before fitting a C collar. So if they meet the nexus system, so if they have mid-C line tenderness, if they have an altered alertness, if they are intoxicated, if they have neurological deficits, or painful distracting injuries. We use the Canadian C-spine rule to determine if they require a C collar. Before fitting a C collar, you want to make sure you ask your patient's consent and that they understand what's going on. So Zara, is it alright if I use the C collar to wrap it around your neck? It's going to immobilize your neck and it will stop any further injuries occurring to your neck. Yeah. Thank you. So before fitting the C collar to my patient, I just want to measure from her traps to her mandible. So I'm counting about 4 fingers. I'm going to measure up to this, which is a short. Go. Push it into place on short, lock, it should snap. So my offsider here, she's just holding Zara's head in neutral alignment and just to sort of keep the head and neck immobilized. So we're going to continue with that. I'm going to put this under Zara's neck, under her chin I mean. Wrap it around. You want it to be decently tight and decently firm. So it's quite restrictive, so she can't move her head or neck. And you want to always keep your offsider or somebody else holding and ensuring that their head and neck are immobilized. When assessing if a patient has a suspected fracture, you would use the PLUS-DISC acronym. So if they have pain, loss of function, unnatural, swelling, deformity, irregularity, shortening, crepitus, or shock. We're going to go ahead and assume that my patient here has a break to his ulnar radius as he's displaying some of those symptoms. You want to expose the wound and assess cardiovascular and neurological integrity before splinting or before doing anything else. So checking the warmth, the cap refill, the pulses, and the colour of the skin. So my patient here, he's complaining of an 8 out of 10 scale of pain. So I'm going to go ahead and administer 2 types of drugs to help manage his pain over a longer period of time. The first drug I would administer is paracetamol. He meets the criteria. He has no allergies and he hasn't had paracetamol in the last 4 hours. This is a longer lasting analgesic compared with methoxyflurane. However, methoxyflurane will be my second drug that I'd administer as it is much faster acting and will take effect quicker. My patient meets the criteria to receive methoxyflurane. He is conscious, obeying my commands. He hasn't had a family history of malignant hypothermia. He doesn't have a renal impairment and he hasn't had it in the past 7 days. So he will be given a start off at 3 mils of methoxyflurane and a gram of paracetamol. Both of my drugs have been previously drug checked by my offsider, who coached him how to use the methoxy, breathing in and out the whistle so we don't get affected by the fumes, as it's a very fumey analgesic. Alright, so I've drug checked both of my drugs with using the 5 R's and it's all in date and it's kicking in as my patient has now got a lower pain score. I'm going to go ahead and splint. We've already checked the cardiovascular and neurological integrity, so if you just want to support his arm proximal and then distal to the break. Thank you. On 3 we will lift. 1, 2, 3 and then back down. There we go. I'm using a cardboard splint which is appropriate for this type of break, and I'm using triangle bandages to secure it. So if you go 1, 2, 3, thank you, and up. If you just want to tie that off distal to the break, thank you. There we go, I've secured it. I would now check the cardiovascular and neurological integrity post-splinting. Our LifePak 12 is a monitor or a defibrillator. Upon turning it on, I want to check it's got sufficient battery charge. Batteries are located at the back of the device here. Push the button here and here. Okay, so both batteries are full. If I wanted to take one out, slot it out like so. I also want to check that there is sufficient paper in this machine. So if paper is located here, pull it down, take it out. Take out, replace if needed to be. Turn the monitor on by pushing on. It will turn itself on. It will automatically turn itself into AED mode I'm going to change that by
connect electrode.
Energy select and selecting manual mode. I'm just going to go yes to 360 joules. Okay, so I want to run an operations check, so I'm going to hit options. Scroll down to user test. And it's going to run through its user test. So over here we've got our diagnostic gear. So we've got our 3-lead ECG, that's present. We've got our SpO2 monitor, it's also present. We've got our end-tidal CO2 detector. The back here we've got our non-invasive blood pressure cuff. Over here we've got our defib stuff, so our pads for humans. We've got 8 GTN. We've got a razor. We're missing aspirin. We need that. And we've got our test load over here. I'm going to connect that. So the user test is passed, so this monitor is safe to use. So we want to show the ECG, so I want to select paddles. As it's connected to paddles, we don't want paddles. Leads. I want the second lead. There you go. So we can see here, it's picking up my sinus rhythm. I can go and change the lead size if I want by going down and selecting size, and this can alter the amplitude of the peaks. So you can see there, I went really, really small. I wanted to change the QRS volume. I would select up here, QRS volume. You can now hear it. I've got my non-invasive blood pressure ECG leads. A good thing to remember is white and black go together, green and red go together. I can also change the lead size down here and change the leads like that. I'm wanting to deliver a shock. I have my test load connected. This is where I'd also connect defib pads. I'll select charge. Okay, it's charging. Charge, so shocking. It's delivered a shock. Same thing goes if I was to charge it and wanted to disarm the shock. So dump it. Just select the knob. Shock disarmed. Is it alright if I take your heart rate?
Yeah.
Thank you. So I'm going to locate Nirvana's radial pulse. Also, while I'm taking her heart rate, I'm going to take note of her chest rise and chest fall for her respiration rate. If you make your patients aware of their respiration rate, it can alter how they breathe and give you an inaccurate result. Over those 15 seconds that I was counting the heart rate, I counted 20 beats. So 20 times 4 gives Nirvana's heart rate of 80 beats per minute. This falls well within the normal range for an adult at rest, which is 60 to 100 beats. Her respiration rate that I counted over the other 15 seconds, that came to 3 breaths, so 3 times 4 equals 12. This also falls well within the breaths per minute for an adult at rest, which is between 12 and 20. Pressure. So Nirvana, is it alright if I use this cuff? It's going to go around your arm. It'll get tight for a little bit, but it's not going to hurt.
Yeah.
It's wonderful, thank you. So I'm going to remove any restrictive clothing from her arm. I'm going to place the cuff with the artery indicator approximately where the brachial artery would run, and I've got a pressure gauge here that will tell me her blood pressure. I'm going to occlude the hole. So I'm just going to pump it up to find out where I need the cuff to be inflated to. So I'll cuff up to 140 millimeters of mercury. That's sufficient so I don't have to over tighten it. I'm going to auscultate where the brachial artery runs, which is just down in here, to get her blood pressure. So Nirvana, I'm just going to pump the blood pressure cuff up again. It's going to get tight, but it won't be tight for long. Is that all right? Wonderful, thank you. So I'm going to shut it off. I'm going to pump it up to 140 millimeters of mercury. Oh, slowly releasing it. The first sound that comes into range is the systolic. And as the sound beats, that's the diastolic. There we go. So Nirvana had a blood pressure of 119 over 80. This is perfectly normal for somebody of her age, or an adult of her age. Blood pressure does... I'm now going to demonstrate how to auscultate a patient's lungs. When auscultating patient's lungs, you want to auscultate the apex and the base, anteriorly and posteriorly of both lungs. So Nirvana, is it alright if I auscultate your lungs? So it's just listening to your lung sounds. It will involve me putting the stethoscope underneath your shirt and just listening. Is that okay?
Yeah.
Thank you. So for this demonstration, I'm only going to listen to the apex of the right posterior side of the lung. Here we go. So Nirvana, can you take a big deep breath in through your mouth and out through your nose for me? Wonderful. For any abnormal sounds such as crackling, wheezing, wet noises, stridor, I heard nice quiet lung sounds, which is normal. If you can't hear any lung sounds, that is classed as abnormal. So we've been dispatched to a 59-year-old male. He's collapsed, unwitnessed, in a residential address. Before approaching the scene and getting to the scene, we're going to consider our access and egress, how far away our nearest hospital is, and how far away our backup might be. We're going to use the doctor's ABCs to check the scene is clear and assess the patient. We want to make sure that there's no dangers to the scene to us, our well-being, so anything like bystanders, pets, wild animals, electricity, water, stuff like that. We don't want to die. We're wearing the appropriate PPE, boots, gloves, safety glasses. So we're going to go ahead, approach our scene, approach our patient. Hi sir, my name is Mikayla, this is Sam, can you hear me? We're from the ambulance. I've got no verbal response. Sam, can you please set up my bag valve mask? Squeezing his traps. I'm not getting any response, so I'm going to check his airway. I can't see anything obstructing it. I'm going to go and clear his chest. I'm going to look, listen, feel for 10 seconds. See if he's breathing. Okay, Sam, he's not breathing. If you could just jump on the chest for me. AUT1 to comms.
Go ahead.
Confirming R49. Can we please have an R50?
Copy, 10 minutes away.
Thank you. Alrighty, I'm going to get my defib sorted. Go. Keep doing the compression, Sam. I'll work around you. So I'm placing the defib pads where they are signaled to go. Turning on the...
Analyzing heart rhythm. Do not touch
Just
the
jump off
patient.
the patient for me, please, mate.
Shock advised.
Alrighty.
Charging.
I'm looking down the patient.
Stay
I
clear
can't see.
of patient.
Still not breathing. So, shocking everybody clear. I'm looking down the patient's
Press the
body.
on button. Shock delivered.
Delivered a shock. Sam, please jump back on the chest for me.
Start CPR.
Okay, I'm going to insert a towel underneath his neck to help open his airway. I'm going to insert in OPA. I'm going to turn my oxygen to flow rate of 15. Go. Using a CE grip, can you count down from 5 for me?
5, 4, 3, 2.
Okay. Chest rise. Chest rise. I got good chest rise there. Okay, Sam, so I'm going to ventilate every 30 compressions. So 30 to 2. So when you get to 25, can you please count down for me?
25, 26, 27, 29, 30.
Righty. Chest rise. Chest rise. Okay, while Sam's doing CPR, I'm looking down our patient's body, trying to see if there's any medical alert bracelets, checking the scene to see if there's any reason why he could have collapsed, seeing if any bystanders or family come home that could tell us what's happened. When the chest rise, chest rise. Ideally, our pads would be sticking. When the AED starts talking to us again, Sam, we'll swap over. So I'll do the compressions and you can do the ventilation.
5, 6, 7,
Chest rise, chest rise. So I'm using a CE grip. I'm getting good chest rise every time I push the bag valve, and so he's got good ventilation overall.
5, 6, 7, 8, 9.
So good chest rise both times there. Sam's doing really good compressions. He's got good depth and good recoil to his compressions. So I'm happy with that.
Stop CPR.
Okay, we'll swap over.
Analyzing heart rhythm.
Come here.
Stay clear of patient.
We've got our suction ready just in case our patient
Analyzing heart rhythm.
vomits.
No shock advised. Pause. If needed, start CPR.
$29.30. Okay, got good chest rise there. Can you just count from 10? So we'd continue this until our backup arrived,
5 and 6,
or we got ROSC.
29, 30.
Okay, so this is our life pack. It is a how do you say it? Defibrillator? Monitor. Oh my god, why can't I get my words today? Oh, Frank, give me strength! Catheter, and for this demonstration I'll be using it. Far out, I'm not wearing gloves!
Yeah.
Oh my god! No, I was on a roll!
You were so good.
Oh my god, guys, like, honestly.
You got this.
Okay. We've got patient catastrophic. So when dealing with a catastrophic when dealing with a catastrophic, make sure that the Botox seal, or the Botox seal, or whatever the fudge is called, is don't worry guys, I'm okay. I'm not okay. Okay, right.
Just film.
Alright. Okay. Alright, so this here is an oxygen canister, bottle far out. Hang on. I'm gonna go bottle because I feel like I'm a space when I say canister. Okay, right. Okay, right, so. Sorry.